Nikhil Aluwalia, who is a cardiology registrar interested in arrhythmia and devices. He's working at St Bart's Hospital in London. He has a podcast helping trainees to pursue academic careers, but today he's going to tell us about preventing thrombotic strokes with the help of Dr. Apple. Thank you.
Great. Hi, everyone, and thank you to Professor Solomon and the Royal College for inviting me to give this talk in this session. I think it's a reflection of the importance of multidisciplinary collaboration in this area of detecting atrial fibrillation for the secondary prevention of strokes. And you'll be pleased to hear that, you might be surprised to hear that in the cardiology conferences, the cardiologists also are doing a very similar approach, inviting stroke physicians to share that perspective to try and manage this condition together. So I put that word in there, disrupt, disrupting atrial fibrillation detection in stroke secondary prevention. And I hate that word. I think it's incredibly overused, disruption. And I guess the question that I want you to think about as I go through the slides in the next 20 minutes is this really disruption, right? Or is it just incremental improvement? Is the use of patient-led wearable AF technologies a disruption in AF detection, or is it just incremental change? Or if you want to send in your questions, is it as far as a paradigm shift, even if we really push the boat out there? So let me show you some evidence. Hold on for the moment, and then please let me know what you think at the end of this talk. So my declaration is probably also the reason why I have some insights to share with you and experience. Two of the investigator-initiated and charity-funded RCTs that I'm working on are using Apple Watches, and one of those is looking at patients with cryptogenic stroke to see if it can serve this purpose. And Apple have very kindly provided the devices for that study, and so that's the declaration, but also the source for a lot of the information and knowledge and data that I'm going to present. We've got a fantastic lineup of speakers here today, so I think my only way to try and compete and try and share some knowledge is to present unpublished new insights and really try and push the boat out. And the reason I changed the title away from Dr. Apple is because there is a lot of innovation going on in this field. Okay, and that's with the non-invasive devices and the invasive implantable cardiac monitors. And we're gathering millions and millions of patients millions of data points and hundreds of thousands of patients with those devices, and we're sort of making new insights, some of which I'll show you. But I do want to try and give you a balanced perspective, because the spoiler is there is no perfect one-size-fits-all solution yet. But we'll go through where the strengths and weaknesses lie, and probably some of the areas where I think there's going to be real disruption going forwards. And towards the second half, in the final 5-10 minutes, I'm going to try and be a little bit more speculative and try and extrapolate the direction that I think these tools are going to take us in. I'm going to present to you some of the information about the study we're doing, and also about the opportunities to personalize other aspects of stroke care using the tools and technologies that we have now. So when this topic is brought up at cardiology conferences, you often hear about how AF increases the risk of stroke by 5-6-fold, how strokes in patients with AF have a much higher morbidity, much more fatal, how it's responsible for perhaps 1/4 of all the strokes we see. But I want to come at it from a different vantage point and really look at the stroke survivors. Okay, and we've got about 1.3 million from the Stroke Association's 2018 data in the UK. And these are patients who have been through the gamut of workup in our hospitals, who've been really provided with first-class evidence-based care. And despite that, we still see a recurrence rate of around 12 to 14%. So despite the best care we can give, we're still seeing quite a high recurrence rate at 1 year. And there are many different, so this is just the info data for some of the recurrence rate from large-scale registries. And one of the reasons why we see this recurrence rate is because of undiagnosed atrial fibrillation. And we know from long-term continuous monitoring using implantable devices that if we stretch the monitoring out for long enough, we find AF in about 1/3 of these patients. And that's been shown at large-scale RCTs, but also in our own local northeast, north central Thames data. We're seeing in about 1/3 of patients have undiagnosed AF picked up if we monitor them. And the reason why I think it's important to pick up on this and why I think this is such a hot topic today is because we have treatment. We have something that we can do to reduce the risk of stroke in the patients when we find the AF. And I put that red arrow here because that's where the difficulty lies. Unfortunately, all the studies that have looked at just blanket anticoagulation, using left atrial size, using risk factors to try and select out the patients who are at high risk without a diagnosis of AF have come back neutral because of the bleeding risk associated with those drugs. So we do really still need to make that diagnosis of atrial fibrillation today before we do something to reduce that risk. And maybe that'll change in the future, but this is the position we're in today. And it's a challenge because atrial fibrillation is a waxing, waning, indolent condition that progresses over time. And there is a little bit of a temporal connection between episodes of AF, but often when you see them and when they're in hospital for weeks, they can be on the cardiac monitor, not show any evidence of AF. If you monitor them for longer than them, you will find it in a proportion of those patients. And the data in that very small graph essentially shows the longer you monitor these patients for, the more AF you find. And that makes sense. I bet if you were to monitor patients for 10 years, you'll find more AF. But where is this balance and what should we do in clinical practice? It's a tough one because we've got a lot of different options available to us. And you'll see your typical stroke patient there wearing a Holter monitor. And that's really been the standard of care for many years. 24, 48 hours of follow-up as an outpatient, very accessible. I think another one of the perks is you can see the data yourself. So even if the test comes back negative or positive, you can corroborate that yourself. And that's a sense of reassurance that I think is quite important. Then, we also have these patch technologies that are available that usually offer a longer period of monitoring, maybe up to 14 days. And they have their advantages, a little bit longer monitoring. And with that, I'll show you some data to suggest maybe a bit of a higher pickup rate. They are still quite accessible. And most centers do have the option to provide this. And from a patient perspective, the abstracts and data I've seen shows that patients like them. It's much less invasive. They can have a shower over that 7 to 14 days, and they can remain active. And then finally, the longest term monitor that's available is your implantable cardiac monitors. And these can, we say about the size of a matchstick, take about 10 minutes to put in, and then can live under the skin there for up to 3 years, continuously monitoring the patient's heart rhythm. So really the maximum amount of monitoring you can perform at the moment in a patient using that device. However, the challenges there are accessibility. Many stroke centers still face long waits if you do want to refer a patient for an implantable cardiac monitor, and of course the cost. And we'll come back to some of the analysis NICE did, but it is probably the most expensive way as well that you can monitor your stroke patients. So where would a wearable device fit in all of this? Okay, and I think one of the things why you might consider this being disruptive or a paradigm shift is once you've had a stroke, if you choose to, you can go out, you can leave a venue like this, leave the hospital around the corner, go to the high street and start your monitoring this evening, okay? And that waiting time is completely eliminated, and it is very much a patient-led approach. Now, there are options to make it much more longer term, but it's not continuous. There are techniques and technologies that the companies are investing in to make the monitoring more consistent, but it's in no way continuous in the way that the implantable cardiac monitor is. Patient experience, in my opinion, has been positive because of the additional perks available with the device, and it generally promotes a healthy lifestyle. But all of this is, my opinion, this table, anecdotal, and it's not really till now been studied in an objective way where we can sit across the table from a patient and say, this is what you should do. And locally, what we've seen, again, reinforces this idea that if you monitor your patients for longer, you'll pick up more AF. And in our local BARTS data, in about 800 patients, we see a pickup rate using a 14-day patch monitor of around 3%. And as you can see, maybe if you can see the slide there, that if you stratify your patients, if you take age as a risk factor, you'll pick up more strokes in patients who are older if you use longer technologies. But with that same caveat, if you were to put in an implantable device, you'll pick up even more AF in those high-risk communities. So what should you do? NICE weighed in on this in around 2020 and released a recommendation to say it is reasonable to consider an implantable cardiac monitor in selected patients for the selected cryptogenic stroke patients for this long-term monitoring. Now, nice and vague language of what selecting your patient means, but it's something that's now in the guidelines there for us to refer back to if you're thinking about it. But everything I've spoken about now is about AF, okay? And I think what we've got to bear in mind is these devices are picking up a lot of AF, but does that necessarily mean AF that we're picking up is the same AF as what your patient would clinically present to you with? So is 30 seconds of AF on an implantable cardiac monitor the same as symptomatic AF that takes a patient to A&E when it comes to stroke risk? Don't know is probably the truth. We do have some data to suggest that AF episodes from devices of more than 6 minutes may increase your risk of stroke, but this is all observational data. The good thing is we are probably a year or two away from the results of large-scale randomized trials to understand this a little bit more, to be able to say where we should introduce that cutoff of how much AF increases your stroke risk. But at the moment, it's very personal to center. And at Barts, we use 6 minutes as a cutoff, but that decision is completely personalized based on the patient sitting in front of you and based on the conversation that you have with them. And I've said, the more you monitor, the more AF you pick up, but the implantable cardiac monitors are not without their own risks and downsides. Okay, it is still, it's a 10-minute procedure, but it is still a surgical procedure where you do have to put something under the skin of a patient, and that brings with it a very small risk of bleeding and infection, which is non-zero and must be consented for before going down this route. And of course, in a patient's mind, when you're consenting them, counseling them beforehand, that is something which is unattractive. And the data that I put in the middle is just showing our own local benefit. Barts, this super cardiac center, as we like to think, it still has a waiting time of about a year from stroke event to implantation of cardiac monitor. We'll say that it's a 4-week wait, and from referral to implant, that may be true, but it's a long way, a path that patients have to negotiate to go from their stroke event to have a negative Holter, to be seen in clinic, to have that reviewed, to be referred, to be counseled in another cardiac appointment, to then be referred on. So it's not as simple as going out to the shop and getting your monitor tomorrow. But another downside is that it comes with cost. And 2018 analysis showed, in the thousands, almost £2,500 is the cost for an implantable cardiac monitor. That must weigh in the National Health Service. And doing the quality calculations, I think it came to somewhere between £10,000 and £15,000 for a quality-adjusted life year that we're achieving using these devices. So it's there, but it comes at a cost, which we must bear in mind. So just before I come to the wearable section, I just want to go back to this idea of what is AF. And the European Society of Cardiology dodged the question a little bit of what we should do with the short episodes of AF, but they have made a very clear recommendation of how we diagnose AF. Okay, and when a patient comes to you in clinic with something, this is the sort of guideline that I would suggest we use. And you can either rely on a 12-lead ECG. Great, we're all used to picking up AF and acting on that on a 12-lead ECG. But the new thing that came out in 2020 was that you can use 30 seconds of a single-lead ECG data and interpret atrial fibrillation from that. And so that is really where we've seen the door open up to these new digital options. And you really have two different technologies that have been brought in with these. And one is the PPG-based technology, which is that red or green light that shines out the back of your watch and looks at the fluctuations in blood volume. But really the thing that you can use to make this diagnosis of AF, and the thing that we're going to talk about now, is the ECGs that are possible by closing the loop using a smart device, a smart watch, and produce a single lead electrocardiogram. And that in itself now, for 30 seconds, if you see atrial fibrillation on there, can be used to make this diagnosis of atrial fibrillation. What you do with it is still up to you. It says there, manage AF, so that still relies on the clinician to interpret the result, but whether it is or isn't can now be made. Great, so we have this idea now of what is AF, but what should we use to try and pick it up? And I've had to think about what I think would be features of the ideal monitor for stroke. And I think that list is up there, and you can add and take away to it from you want to. And let's have a think together about where a wearable device would fit in on this scale of factors. And of course, bear in mind that I'm going to be talking about the data from the Apple Watch because that's what I've got access to. But there are many other companies that have a CE mark for doing ECGs in patients for the diagnosis of atrial fibrillation. And that's all the companies that you see there. So how does the Apple Watch fare, or wearables fare on this spectrum? And I think in terms of accuracy, we've got a good idea. The ECGs that we've seen thousands through the studies that we've been running at Barts, and most of them have a good quality. The good thing is, if you have a poor quality ECG, you can just ask the patient to do another one and send it through to you. So there is that option to refine, reproduce, and repeat. Now it is, of course, very patient-specific, and the very final point, which we'll come to, is ease of use. And so it is very much user-dependent still. And it does require some patience and keeping your arms on a flat surface to record an ECG. But we know that ECG is enough to make the diagnosis of atrial fibrillation. When we look at how it performs alongside Holter monitoring or telemetry, actually the sensitivity and specificity is pretty good. Now, the thing to point out there is there's lots of nuances to this. So first of all, we haven't seen here what the PPG-based technology, which is the light shining, is. That was studied in a much larger study, the Apple Heart study, and it came to around 0.7, 0.8 sensitivity and specificity. So that alone is not good enough and not really recognized by the ESC as sufficient data to be able to draw that diagnosis from. However, this probably is, but it still relies on your interpretation and you to make the diagnosis. And what the bar chart shows from there is from 400 patients undergoing cardiac surgery, that if you relied solely on the automated analysis from the watch, you were getting probably a sensitivity around 40%, which is clearly not good enough. But if you were to print off these ECGs and stick them in front of a doctor, that number went up to around 96%. So the data is there, but it still requires a human to, a trained, experienced doctor to look at it and go forwards with it. So accuracy is there, but still needs a person. But what about continuous? And yeah, I think the challenge here is that the Apple Watch and wearables are not continuously doing ECGs unless you're walking around like that all day, which is clearly not feasible. However, they are still monitoring the heart rhythm in the background, and that's very similar almost to some implantable, well, probably a little bit different from the implantable cardiac devices, but they're constantly monitoring the heart rhythm. And if they detect a fluctuation or a change in sequential readings, they will prompt the user to do that recording. And what we know from Holter monitoring data, that the more Holters you do, the more AF you predict. And so if you were to do one annually, you get one pickup rate, one sensitivity, but if you were to then increase the frequency to monthly, that's higher. And I suspect if you increase that out to daily, that line will continue to trend upwards. And that's the sort of thing we're looking at with an Apple Watch. And again, the data isn't there for us to be able to say clearly where we stand using these devices today, but hopefully in a few years we'll have that data there. But it's close to continuous if you were to request your patients to do it frequently, up to daily. And that's what we're doing in our study, which I'll come to in a second. Now, I think the third aspect that I think is important is real time. Okay, so often when patients have Holters, it still requires that to be sent back and analyzed, and there is potentially a delay of clinical interpretation and action. And the advantage of a wearable device is the patient can take that recording and export it and send it off to the PDF to their doctor. And that, I think the first thing many of us will think is, what do I do with that? Is that then up to me? Where do the medical legal responsibilities of that lie? Still very valid unanswered questions, which we don't have. I don't have an answer to yet, but there is the option for us to react to an ECG within 30 seconds of getting it and really incorporate it into the workflow of a device clinic style model where alerts from pacemakers, ICDs are reviewed on a regular daily basis and work that into a model if we can demonstrate clinical benefit. Yeah. The thing is, you'll see stuff like this, and this is from a patient a stroke patient who's in the study that I referred to. I guess the question now is, what do you do with that? So the ESC was clear that 30 seconds, if you believe this is continuous AF, you can call that AF, but this is tricky, right? And probably not AF throughout. And so you reach these gray areas where you've got 30 seconds of data, but is that 30 seconds of AF? The truth is you probably can't call that atrial fibrillation if you are strictly adhering to the guidance, but it's an option for you to then say to the patient, there's some abnormalities here, can you just send us another ECG? Or can you increase the frequency in which you send us recordings and react in a very personalized way, which is nice. So going back to the idea of workload, what does this mean for us? Let's imagine, a few years down the line, we move to a model where patients are sending through ECGs left, right, and center. And it is a struggle. From a research perspective, we've got, thousands of ECGs coming through a mailbox, which we have to react to because that's our study protocol. But also you have the ethical responsibility to react to abnormalities that would change the clinical practice of patients. And this is not all stroke patients. We're also doing one in patients who've had an AF ablation. And so, that's another reaction that you may have to take. And so it is workload that's there. However, the thing I would say is all the data that comes through is all open source. It's very user-friendly in the sense you can pull it all together, make nice graphs, and accumulate the data to react on it as a whole. So the tools are there to be built. And once they're built, the useful thing is that you can then extrapolate that and share that across the country so that you can share the management of it. And then finally, it's this idea of, is it easy to use? And again, I think this is probably one of the biggest challenges that's there today for us, especially when we're seeing stroke physicians. The dexterity needed is significant, and it's probably one of the things that we do need to evaluate in this real world way. So finally, that's the study that's going on. We're working across a couple of different of the hyperacute stroke units across North London, and we're enrolling patients who've had a cryptogenic stroke to either continue with standard care or standard care plus an Apple Watch. And then I know we're getting close to time, so the additional points I want to make is a lot of this might seem quite enthusiastic and quite positive, but there's a lot of caution needed. Okay, a lot of this is still conjecture, ideas, and that's really the rationale for pursuing the research, but we must remember that this is just a 30-second recording. It requires medical interpretation. Do we still see the same relationship with stroke that we want to? And of course, the biases in a system like this. Looking at our data, we are probably enrolling much younger patients, perhaps wealthier. We haven't got that data to see, more Caucasian patients in the data that we've seen, so we've got to bear that in mind. However, I want to leave on a final note to say that there is a lot of unexplored new territory available with these devices. You get all sorts of new data, such as step count, activity count. Patients can record their symptoms, tell you how they're feeling, and you can really collect what is meaningful big data. Well, you can collect big data, and then the question for us is, how much of it is meaningful? How can we tie it together? What can we do with this analysis? And so really, the thing I want to just say as a final plug is, please do get in touch if you have any ideas, if you have any thoughts, if you're a motivated trainee who wants to explore doing some research or work. We've got a huge amounts of data that are going to take a team of people to really analyze. If you're running a service and want to explore and understand how to use this sort of technology, would love to have a chat about it. Always open email to talk about that. And if you do have any questions on a other basis, please do get in touch. Thank you.